when students come in, a lot of the students, while we try to vet you and see where your experience level is, we don't know exactly where it is. Because some students say they can suture, some students they say they can do this and they can do that, and there's not. So we decided to have a nightly pre-course, whoever wants to come, to go over some of these techniques and some of these information. But mostly what tonight is what really is important for is to get you familiarized with the implant systems that we're going to use tomorrow, okay? So we want to eliminate the nebula tomorrow, and when you show up and you're like, I don't know what to do, what's going on here? I got this drill, I got that drill, I got all this stuff going on. So we're going to try to iron some of those things out tonight, okay? It's going to be a brief lecture on some treatment planning, very brief on surgical guides, and ultimately tonight's intention is to be on hands-on, okay? Let me just get a heads up, who has placed implants or is placing implants? You're placing implants? Have, okay, that's fine. And you haven't placed implants. So one of the things tonight, we're gonna learn the difference between D1, D2, D3 bone, D4 bone. This is a classification that was set up by Carl Misch many moons ago, and it's based on wood, okay? So we have some examples of that tonight. We have 2 kits that we're gonna be using tomorrow for the most part. Actually, there's gonna be 3 kits, but one of them is blended. So there's a freehand kit where you freehand some of the implants. Most of the implants in the case in the course tomorrow are set up are basically guided cases, okay? But there's nothing saying you have to do it guided. You can do it freehanded. A lot of it has to depend also on the instructor you have. So when you guys are paired up with other students in the institute, they'll pair you up. They'll give you patients to do. We always start out first thing in the morning. Dr. Rasner goes over the cases. He does his lecture, goes over the cases. And then basically you'll be paired up with a partner, and you each will assist each other in the surgery, and you'll have a proctor in the room, okay? One of the instructors. Really depends on who you get. Instructors such as myself, depends. I tend to love surgical guides. So I do everything guided. It's not because I don't like freehanded. I did freehanded for about 17 years. And basically at my 18th year, I decided, I'm going to start doing guides, and I've never gone back. I love doing guides. You can always take the guide off from freehand if you have to, okay? There's other instructors in the course. There's another one you'll meet tomorrow. He may come tonight, I'm not sure. That he looks at a guide and goes, all right, whatever, and he loves to freehand it. So it's really the flavor of what you guys want. We try to tailor the course to you guys, and we really, as instructors, work really, really hard to make sure you guys get the best experience.
We'll engage the buccal, come through the palatal tissue in this case. And typically I would use this, let's say you're doing an extraction, you add a bone graft and you put a membrane over that. You want to make sure that the membrane stays in place and have it tacked down. So I went from here, buccal to palatal. Now I'm going to engage the buccal tissue again. Coming out through the palatal. If you take a look at this, as I come across and tie this off, once again, tooth rows. You can see the X or the cross mattress that I just did. As I said, typically I do this if I'm doing a bone graft with a membrane and I want to keep the membrane in place. Because now you've just come across the crestal tissue here. And the tie is always the same. Tooth rows in the same direction twice, and the third row is in the opposite direction.
Tonight is my amazing associate Gabe and Trey's night. I do want to say one thing though, because he said something. And look, when you enter implant dentistry, which obviously you're all about to do, or take it up a few notches, there's a lot of ways to approach it. And you're going to hear a lot about me talking about this concept tomorrow morning. But I'm all about, dentistry's hard enough. Are we all GPs in here? So dentistry's hard enough. So I'm all about breaking everything I do down to the easiest dimension to make my life as a person and as a dentist better. So one of those ways, like I don't know anybody that does it the way I do it. I don't know, you might do it that way actually, Gabe. But like you don't have to do this. So you go online and you can get miserable watching guys print things now and do all that stuff, right? That's the print and save $100 and not do it don't hire a company. And 3DDX is not the only company. Obviously you have 360, what's it called? Imaging? Imaging. Blue Sky, is that what it's called?
Blue Sky Bio.
There's a million of them.
Osteoid.
You know, and I'm not sure that 3DDX is the best. It's one I've used, and if you used them and tried them, you would kind of get it. You'll like using them too. They're based out of Massachusetts, and it's this incredible, elegant group of dentists located in Egypt. And when you ever call Four Seasons Hotel or Ritz-Carlton? That's what it sounds like you're talking to. Like, I do these every week for 2 hours, like on Fridays and on Tuesdays. That's how many guides I'm doing. 100% of the time I'm late, right? So I call, and they call me at like 4 o'clock, or so the call's supposed to be at 9 o'clock on Friday morning, and something's happened. And can you call me back in 5 minutes? I mean, I'm sorry. Oh, absolutely, Dr. Rasner. Is there anything else we could do for you? Would you like us to take your laundry and drop it off today? I mean, I love working with them. They're incredible. So here's my workflow real quick about this. We decide we're doing a case, or we think we're doing a case, because I don't always have the time in the middle of my day to go over to my CBCT and start breaking it down. I don't even want to do it most of the time. So I dedicate a different time, and you will too. Maybe yours in the beginning will be whenever you need to do it. Maybe it'll be once a month. I don't know. And I go in and there's your case that you downloaded, and you tell your friend. This is what I do. I tell my front desk there's somebody in charge of that. I don't do any of it. Front desk says, okay, we're going to play. Where's this implant at on this case?
Listen, you got 20, 22, 23, 26.
Is this a real case tomorrow?
Yep. I just took the name off. But.
Okay, beautiful. So this case, they got a CBCT. I told them what the case is going to be. In this case, it was 6 implants. I'll say something like 4 to 6, probably in the positions of such and such. I want you to follow me, because this is what's happening. For a Zest locator overdenture. So I got to tell them what you're doing, because if you do Zest locators versus obviously an all-on, you're going to be taking down different dimensions of bone. So you have to give them that. And that's all the information they have. And then I show up, and at 9 o'clock, there's a phone call to me on my computer, just like he's doing, and my case is up there on the CBCT, and they've already spent time planning it. They've given their shot at what they think this case should be. But I'm there saying, wait a minute, we can get another implant or 2 in here. Maybe they started with 4 on them. Because I'm not going to go into tonight, but if you're going to do Zest locators, I'm using more than 4 most of the time. Okay? And it's a very common implant design you're going to do for patients for no other reason than affordability. It's the cheapest way to attach an implant to the mouth, right? So then you're moving them around, and you're getting all kinds, and here's what I like. They're backing you up. They're showing you things that you may not have seen in your office on your CBCT, right? There's a couple cases tomorrow where they're pointing out anatomical structures that I forgot about. I'm not talking about the inferior alveolar nerve. I'm not talking about that. I'm talking like a branch of something. And maybe we want to go around that. Not because we would hurt the patient, but there'd be excessive bleeding, and I don't want to freak any of you out tomorrow. or Saturday. You know, and it's good you to know that, because that's going to happen in your own practice. So that's, I don't mean to interrupt you, but this is a big key of the way that I deliver these. And then they, at the end of the day, you got to say, sign off on it. That's verbal approval. And in 3 days, you have your guide. Okay? And you're going to do three kinds of guides. You're going to do tooth-supported guides. Doesn't get any easier than that. Did you go over that yet?
I briefly went over this.
You're going to get combination tooth and bone. I don't do soft tissue supported guides, and I'll explain that tomorrow. In other words, I never want you to have a guide made and you plop it on top of tissue and you go through it. I mean, you fixate it with pins. I think you should see where the implant.
With experience in extractions? Okay. You might not be experienced in the Rasner way, though. So it's a little bit different. It's different from, it's different. I'm going to go into that briefly a little bit. Today's not the extraction course, but I'm going to give you some taste of it. You're always welcome to come. We're open books. You're always welcome to come to us and ask us any questions. Every instructor here, truly, we instruct for the love of instructing. We really enjoy doing this. And basically, you know, we come to us with whatever questions you have, and whatever we can help you with, we'd love to help you. Okay, so here we go. Let's get started. So the objective is to familiarize yourself with the basic knowledge of implant dentistry, placing implants, I should say, and get your ball rolling. This course is actually tailored to the beginner person all the way up to some of the more experienced patient or docs that have placed several implants and are very familiar with placing implants. So the course outline is we're going to go over some implant treatment planning, site development, implant placement. That's where we're going to spend most of our time. Okay, I'm going to spend most of the time. We're going to be going over the guides. Like I said, there's 3 guides we got to get used to here. We got to understand and know. And it can get a little confusing, but we'll walk you through it. Okay. Flap design and closure. That is Trevor Sue, Dr. Sue over there. He's a periodontist. He's basically a master at this. We have 2 periodontists in the course, and they're the people to talk to about opening, closing, and flapping and flap design. And you know, it can make a big difference in your surgery, make it or break it. If you start off with the wrong flap design and now you're doing something and you're trying to graft and now you can't gain that tissue, you're in big trouble now. You know, and it can just because from step 1 you have now put yourself behind the 8 ball. So he's one of the people you definitely want to talk to. And then definitely we're going to go into the hands-on portion. We want to spend most of the tonight on the hands-on portion. So you might find that, excuse me, that I'm breezing through some of the lecture. And please, it's not by design. It's because I have a lotted amount of time and I have a huge lecture. But pull me aside if you have any questions. Pull Dr. Rasner aside. By all means, we're open. Let us know. Okay, so here's some of the instructors for tomorrow that you're going to be involved with. Dr. Rasner will obviously Dr. Rasner, Dr. Holwager, Dr. Sue, Dr. Tenosha, Dr. Leventea, Dr. Mitchell, myself, and then Dr. Sue. And he probably will introduce us tomorrow and everybody will get a little more acquainted. Okay, so implants. One thing is to just be able to put an implant into bone. Back in the 2000s when I first started placing implants, 90s, 2000, it didn't matter. It was acceptable just get an implant in there. Who cares if it had suppuration 2 years later? Who cares if it didn't have soft tissue around it? If it stayed fixated in that was considered a successful case. Those standards by nowadays are not acceptable. So you have to have the ability to place an implant, and it's got to look good prosthetically, it's got to function prosthetically, and it's got to be cleansable prosthetically, and it's got to have something that's very important that nobody really pays attention to. I shouldn't say nobody, but most of us focus on this last, soft tissue. Soft tissue is extremely important in your implant placement and the longevity of your implant. You can have the most beautiful implant placed on an x-ray, have no soft tissue. In 2 years, you're going to have crestal bone loss. In less than 2 years, you'll have major crestal bone loss. So soft tissue is the most important thing. Okay, exactly what I just said. We got to basically develop our treatment plans based on prosthetics. Just because you can put an implant in there, just because it looks like, oh, I got bone there, I can place an implant, but I have basically bone a huge concavity there, and yes, I can get an implant in there, but now you can't keep it clean against adjacent teeth. Is that really a proper treatment plan? Maybe a bridge is a better option. Just because you can get an implant in there does not mean it's the right choice. Okay? I'm going to make that abundantly clear. Okay. So, bone loss in the area. Okay? This pertains to loss of implants. Sorry, I apologize. Loss of teeth. When you lose your teeth, we have a couple, nobody pays attention to this in the sense of it details didactically, but we have a couple laws like Wolff's Law, where if the bone's not stimulated from a root system or an implant system, or you have no strain on the skeletal system, you lose a percentage of bone over the time, okay? And 25%, if we have an immediate denture, you can lose up to 25% of the bone within the first year, up to 4 millimeters of height within the first year. Okay. Bite forces. You lose your teeth. Your bite forces go down dramatically. If you lose all your teeth, you're going to be in the fifth.
All right, I'm going to try to go through this quickly because I know we've been taking a lot of time with the last part of it. I'm not here to keep you all night, but I do want to just kind of go over some very fundamental, basic flap techniques and designs, because I think that's going to be important when you're using this particular system where, as you heard from Dr. Rasner, he wants you to be able to see the bone, and there's going to be advantages and disadvantages with flap versus flapless approaches. So I'm here to kind of give you my spiel, my kind of biases when it comes to, as a periodontist, soft tissue, flaps, and suturing. All right. So we're going to really just kind of outline. Let me kind of see. Just kind of some basic principles and techniques, why we do what we do, why I'm telling you this is what I do. And like Dr. Rasner says, find your own kind of, well, see, after you get the information, put it together, try things out, see if it makes sense. You're not here to copy and emulate me. If you like what I do, great, take it. Same thing with suturing. That becomes even more subjective than even flap design. So different people may suture differently, but the fundamentals is still there. I think it's important, especially with someone who educates and dental students all week long. You start with the basics, building blocks, and then you build from there, and then create your own kind of, way of workflow and how you do things. So I'm here to kind of give you some fundamental stuff, just information, and then why we do. And to me, that's really the most important thing, why we do what we do. Because if you don't understand the rationale behind a particular skill, technique, it's hard to kind of build from that. So that's important, you'll see. And then of course, we're gonna spend some time on suturing, and then what we use for various types of conventional surgeries. And a lot of what I do, like I said, is very basic stuff. But before you can raise a flap, you actually have to understand what incisions are you gonna make, because that's gonna end up designing and creating your flap. So incision design comes before flap design, and it's important for you to get a handle and know how to do that. So when it comes to incisions, you can have it in various places in a different fashion. So I'll boil it down to really, where are you doing it? You could be doing it on the crest of the bone, of the soft tissue overlying the edentulous space, or you can do it subcrestal, which is going to be a little bit past the crest, usually a little bit off to the lateral sides of it, whether it's buccal or lingual. And then there's the releasing incisions to allow you more access apically. And I'll show you diagrams of all that. But the purpose of a flap is always to improve access. So I've seen many who struggles taking out a tooth because the first thing that I do when I go and try to help a student out is I raise a flap. Because they always try to take the tooth out without raising a flap because it's easier, they feel it's like it saves time. But if you don't have proper access to tackle on that procedure, a flap almost always will help you out, and it's important to kind of keep that in mind. And then there are the other kind of the reasons that I use it is if I want to move tissue around. So as more advanced procedures we can go into, but we won't have time to do it today. But if you want to kind of manipulate and move soft tissue like gingival grafting or bone grafting that requires changing the volume of that site, then you have to manipulate tissue. Then various flap designs will allow you to transfer and relocate tissues. So Diagrammatically, this is kind of what we're talking about. So we're working around teeth. Around the crest will be right around the tooth, right at the gingival margin. If we want to change the location, set a new gingival margin, then you're looking at what's called subcrestal or submarginal. And then lastly, if you want to confine the space of your access, you want to keep your flap to a smaller kind of an area, you can use releasing incisions and still be able to get you better access while not extending the size of your flap or length of your flap. And then the types of flap, for the most part, 95% of what we do of our surgery, it's going to be a full thickness flap. But like I said, if in the rare occasions, if we want to do specific types of treatment that allows us or requires us to relocate and transfer tissue, then a partial thickness flap is more likely going to be helpful for that. I'll show you examples of those things, but our emphasis will be on full thickness flaps, because again, for implant dentistry, almost always you're going to need a full thickness flap. And if we were to preface this course with the extraction course, almost always you're going to need a full thickness flap. Anytime you need to get access down to bone, unless you're not looking to have any interactions with the bone underneath, then you can maybe get away and minimize it to a partial thickness flap. But anytime we need to work in bone, whether we're making an osteotomy, making a hole in the bone, or we're getting down to bone to separate a tooth and extract a tooth, you're going to need a full thickness flap.